Hi, I'm Kim Keebler, the editor-in-chief of the Multiple Chronic Conditions Resource Center, and we are pleased today to introduce Dr. Jordan Yakoby. He is a neuroscientist and a fellowship-trained acute care nurse practitioner in neurocritical care and stroke neurology. He completed his fellowship at Capital Health Regional Medical Center in Trenton, New Jersey. He is currently Associate Dean and Associate Professor at Adelphi University. He is an inducted Fellow of the American College of Critical Care Medicine, American Association of Nurse Practitioners, Neurocritical Care Society, and the New York Academy of Medicine. And Dr. Yakoby, I have to tell you, I was so impressed when I saw that you had fellowships in medicine as well as nursing. He is passionate about the provision of critical care and nursing education. In 2023, he was appointed by the Secretary of the U.S. Department of Health and Human Services to the National Advisory Council on Nurse Education and Practice. The Council advises Congress and the Secretary on matters related to nursing education and practice, workforce development, finance, care delivery, accessibility, and other issues under Title VIII of the Public Health Service Act. Dr. Yakoby serves on the boards of directors of several organizations in the area of anti-human trafficking. He serves at the Freedom Network USA in Washington, D.C., Sexual Violence Treatment and Prevention at New Jersey Coalition Against Sexual Assault in Trenton, New Jersey, Education at the Chicago Collegiate Public Schools in Chicago, Health and Research at Neurocritical Care Foundation in Chicago, and he is a panelist at the New York State Justice Center for the Protection of People with Special Needs in Albany, New York. He is a practitioner, author, scholar, and patient advocate, and we are pleased to have you with us today and to learn about your expertise.
Thank you. It's wonderful to be here.
So I was also very impressed with your recent authorship with the care consensus statement on teleneurocritical care. For the audience, can you describe your guideline committee and the whole process of this publication?
Sure. So I was one of several co-authors to spearhead this effort to establish, for really the first time, standards and expectations for the provision of neurocritical care remotely. Our specialty is one that is not common at every single hospital, and it's important for those in more rural settings to have the same access to care as those who live in urban settings. And so we looked at how to provide appropriate care, what the resources, both physical, financial, and human resources that need to be at the hub site, that primary site, and also at the spoke sites, so that not as many people would necessarily need to be transferred from their local hospital and where they also live and are near family, and they could receive those neurocritical care services remotely. And so we were able to make a consensus statement, both based on the evidence and also on our expert opinion on how those services should be provided. And we're also very proud to say that a number of other professional organizations endorsed our guideline, including the American Telemedicine Association. And then several others also endorsed the value of the statement, including the AANS, the Congress of Neurosurgical Specialists, as well as others.
It's very impressive. So tell me, what kind of professionals would be accessing your services?
Certainly. So, and specifically within, the teleneurocritical care consensus statement, then, you're really looking at intensive care specialists and other medical specialists at hospitals where there is no dedicated neuroscience ICU that would be reaching out to the primary neurocritical care unit to receive that specialized neurologic critical care guidance to help steer the ship, as it were, for the patient at that remote site who is suffering from a neurologic injury, whether that be stroke, hemorrhagic stroke, or some other neuropathology that requires them to be in the intensive care setting, but maybe not be quite as acute as to require transfer to that tertiary or quaternary care center that's providing that specialty consultative service.
Yeah, I'm in coastal Georgia. Central Georgia is pretty rural, and the tertiary facilities are, 3, 4 hours away. So I can imagine that this is a great resource for settings, that don't have access to triage. That's important work. So you're also a clinician. Hemodynamically, you have to pay attention to all body systems with patients in the ICU. And I assume that there's a specialty for each system. So how do you coordinate care communication between all of the specialty members and ensure patient and family engagement?
Well, certainly, that's a wonderful question. Fortunately, as neurocritical care professionals, we are a full-fledged ICU team. So I always say that neurocritical care is the marriage of neurology and general critical care. So not only do we manage the neurologic aspect of the patient's care, we manage all body systems. So, we manage the pulmonary and cardiac issues, including the ventilator, hemodynamic issues they may have, whether it's blood pressure augmentation, or if we need to reduce the blood pressure because they've had a fresh intracranial bleed. So for this reason, because we are a full-fledged critical care team, that does reduce the amount of consultations that we need to other professionals. But at times, as you can imagine, that's still required. If a person has a severe enough acute kidney injury, for example, and they need dialysis, that would certainly warrant nephrology consultation. So we do take care of that. But I think part of that is because we are those ICU specialists, we can handle a lot of complex needs that they have. But as you mentioned, coordination of care certainly is important. And what we do find as a challenge a lot of times is that sometimes our consulting colleagues may not fully appreciate how a particular cardiac or renal issue may be at the intersection of that neurologic issue. So for example, I gave the issue of dialysis. A lot of times we need continuous veno-venous hemodialysis rather than their intermittent dialysis that they may have on a chronic basis. They may have end-stage renal disease and get dialyzed 3 times a week. Well, actually a neurologic injury, having that rapid exchange through a 4-hour session can actually cause cerebral herniation. And so sometimes we find that other professionals, they may not be thinking about that, and we have to really call that to mind and coordinate care on, instead of doing intermittent hemodialysis, we need to do CVVH. Or how sometimes cardiology, they may have competing interests. They have troponin leakage, like a type 2 MI, but they're also having subarachnoid hemorrhage, and we may need to increase their blood pressure even if they may have chronic cardiac conditions, and that sometimes makes our cardiology colleagues a bit nervous. And so really it's through a lot of sharing the latest evidence-based practice, why we do the things that we do, and how can we minimize what their concerns are in terms of the risks versus what needs to be done for cerebral perfusion pressure and other cerebral hemodynamics, and helping our colleagues to understand those things and how those issues intersect, and where we might be able to have a meeting of the minds, if you will.
Yeah, and how is the patient and family engaged in all of that communication? It has to be a scary time for them.
Yes, not only is it a scary time for them, and as it would be in any ICU setting, but I really think that in neurocritical care, the relationship that we have with families is even more special. You know, all of our patients in the ICU, or nearly all of them, I should say, I can't say that that's an absolute, but nearly all of them really are not able to make decisions for themselves. So that patient autonomy is not really there. Maybe they have aphasia and thus are not able to speak or really fully understand. So a lot of times their own judgment and their insight and their understanding is impaired. So you're really going to lean on the family even more so than other settings. What would this person want? And because we're also talking about neurologic disease, we're also talking about quality of life and recovery. What would an acceptable quality of life be for this person? We have to prognosticate very frequently. So to what extent are they going to be disabled? To what's their morbidity look like? What does it look like 6-9 months from now? Can they do, and would they be okay with that? And so it's very difficult to have those conversations with families. Unlike chronic illness that you might find in a medical ICU, a lot of times we have patients, they were at the dinner table and 1 minute they were fine and the next minute they were not. And so that's also really hard for families to wrap their minds around, is the sudden nature of some of these acute neurologic disorders, especially cerebrovascular ones, and to get them to emotionally cope and to be able to make decisions in the best interest of the patient according to what that patient would have wanted if they were able to speak. So we have a very close and special relationship that is at times very challenging to navigate because of the nature of the beast.
Yeah, I can imagine. And a lot of these patients, I'm sure you mentioned some underlying etiology, other conditions that bring them into the ICU, the acute setting, but they are often living with chronic conditions, multiple chronic conditions like hypertension, diabetes, obesity. So you still have to manage those diseases while you're, focusing on the acute nature of the condition. So how do you keep all of that hemodynamically stabilized?
Absolutely. That's also certainly absolutely correct. Many times they have a neurologic issue, as you mentioned, as a result of a chronic condition. Perhaps they smoke, perhaps they have uncontrolled hypertension or diabetes, undiagnosed atrial fibrillation, lack of access to care, so that they're unable to follow up. These are all chronic and very frequent issues that we do see as part of the presentation to the neuro ICU. And so really what we're doing is we optimize a lot of those chronic issues. We do screen for high cholesterol, we screen for diabetes, among other reasons. Understanding why someone had some kind of cerebrovascular event is all about the etiology. Looking at, was it small vessel disease, and if so, then was that because they're hypertensive, they're poor glycemic control, or do we think that it's embolic, and so they had an occult atrial fibrillation? And so we do a lot of testing to understand what the underlying issue was, and then creating a treatment plan, not just to get them through the acute issue right now, which might include cerebral edema, intracranial pressure crises, or some of those other acute issues, but also, okay, so once they leave the neuro ICU, what will be their plan for anticoagulation? What plan will be endorsed to the hospitalist team or the rehabilitation center for their glycemic and their antihypertensive control, so that they have a firm plan communicated to them and that they can stay on that plan and follow up? Because we find a lot of clinicians of any stripe, of any academic discipline, if you will, are not comfortable managing cerebrovascular and other neurologic disease, and so they really lean on us to make that plan for them ongoing until they can be handed off to a stroke neurologist that will see them on a more ongoing kind of chronic basis. So it's very important for us to think about not just, okay, what's going to happen today and tomorrow, but what are they going to be doing over the coming weeks and months in terms of managing those chronic conditions that landed them here in the first place.
Yeah, and that's the patients that I see, the post ICU. So I think it's really important that you're focused on their future to improve their physical functioning. So we just did a podcast on the recent guidelines, the 2026 ischemic stroke guidelines, and the idea of timing. So in your practice and in your clinical setting, timing is everything, right? To prevent debilitating symptoms. So what advice would you give to other healthcare professionals, patients, and families to prevent debilitating symptoms in any neurological condition?
Certainly. So, of course, it's long been known that time is brain. It stands, it goes without saying, really, that, the earlier you recognize and can get them to definitive treatment, the better. But, really what I would like to highlight also is that window of treatment is progressively getting longer and longer. For example, after the Dawn and Diffuse trial several years ago, we were able to see that with the help of perfusion-based scans, we can extend the amount of time that we're able to offer mechanical thrombectomy, for example, with ischemic stroke. There are also trials ongoing about giving intravenous thrombolysis beyond the historical 4.5 hour window. And so we can expect to see that those treatment windows will expand in the near future, whether that be, for example, tissue and perfusion-based imaging to help us with that. And so I would say don't rule out the possibility for a patient to have a potentially life-altering and improving acute stroke treatment just because it may be 6, 7, 8 hours after symptom onset. Really refer them to us anyway and let us guide you in deciding what neurodiagnostic testing needs to be done, and we'll make the decision about whether they qualify for any treatments, because really this is almost like a moving target now. We're really making a lot of leaps and bounds in this field, and so we still may be able to offer the patient something even if it may not be apparent to you. We may even, if they're not eligible for reperfusion therapy, depending on characteristics, we may be able to do blood pressure augmentation and other treatments that might be able to at least minimize the amount of tissue that progresses from at risk to death, and kind of minimize that penumbra, if you will.
Yeah, well, thank you for that. And I'm thinking, in terms of primary care, I'm doing primary care for an indigent patient population, and I see, very unhealthy people. What advice would you give to primary care clinicians or practitioners? What key things should we really be thinking about to prevent an acute event, a neurological event?
Sure. So I also, as you mentioned, I'm an educator, and I always teach my students what I call the unholy trinity, and that's hypertension, hyperlipidemia, and diabetes. These are major causes of cerebrovascular morbidity and mortality. So really paying attention to what are the guidelines for these disorders. That's, it's really back to the basics. So I'm not saying anything that no one doesn't know, but it really is about back to the basics and managing those risks. But also, understanding the cultural context in which the patient finds himself. So a lot of times we tell people about the importance of adequate nutrition in managing diabetes, cholesterol, and hypertension. But one thing that I'm finding is a huge problem is we're not doing it in a culturally competent way. We may be telling someone that it's from a Hispanic background or any background they need to follow the Mediterranean diet. How many times have we heard that? But is it really realistic for someone not from a Mediterranean diet to follow a Mediterranean diet? Do they know what that is and how to follow it? And is it appropriate to tell someone that, okay, you need to follow this culture's diet, not your own cultural diet and preferences? Rather, to make that counseling culturally competent, maybe learn about what foods are important to them, because that's really what touches the soul, right? And then counseling, how can they make their favorite dishes, but maybe in a way that is a little bit more healthful. And I think that would also help with the nutritional aspect to kind of drive some of these issues with glycemic control and cholesterol and so on, to make healthier choices within the cultural context that that patient finds themselves. Also being mindful about social determinants of health. We've been pushing that for a long time, but really digging into what are the difficulties that drive them maybe not to be able to meet their defined health outcomes. Not labeling people as non-compliant, but say instead, okay, the patient was not able to adhere to this regimen because of, and document in the chart, and then document what steps you're doing to help them meet those goals. And so those are some of the ways that I really think we can shift our thinking to help them prevent acute issues from whatever chronic problems they may have.
Yeah, when you talk about cultural differences, I see patients with interpreters. I have interpreter services, and trying to teach a Hispanic patient about their cholesterol, their diabetes, and have an interpreter, trying to express that. That's a real challenge too.
It is very much so, because sometimes some of the nuance of what we would like to impart could get lost.
Yeah, I mean, I don't know what they're saying. And, sometimes I'll get the same question. I just, inform them about something and I get the same question. So I'm like, well, I wonder what they heard, or what was interpreted. So yeah, it's very important. So just curious, what specific vascular risk factors should be considered to improve patient-centered outcomes and in preventing the occurrence of a future stroke?
Sure. And, again, it goes back to those three I mentioned, the unholy trinity. Hypertension, hyperlipidemia, and diabetes are the biggest vascular risk factors, but we can't forget also things that, are modifiable risk factors, such as tobacco abuse. We're also seeing strokes in a much younger population. So I would also urge people to assess other risks. If you have a family history of stroke, especially at a young age, it may be worth talking to your primary care physician or your primary care provider whether you may be at increased risk, and understand, are there certain heritable diseases that may result in so many people within the family with young stroke. We call that stroke in the young. But then also, we have risk factors even younger, such as vaping is becoming a real epidemic as well, and that's something that we should also be regularly assessing for also.
Really important stuff. So, in your opinion, what do you think that the general practitioner, I know we just talked about that a little bit, but what sort of pearls would you give a general practitioner in day-to-day clinical practice? Like I have 23 patients running between, interpreters and really unhealthy people. What kind of pearls would you give, a clinician who's facing that type of clinical practice?
Sure, is always be looking for possible modifiable risk factors that we can counsel and coach patients through. The tobacco abuse, sedentary lifestyle, nutritional choices, regularly asking about family history, because these things are moving targets. We ask perhaps one time at intake 5 years ago during the history and physical, what are your family history, but we never really revisit that again. So maybe again asking, how do various family members fare in terms of their health? And if they say, oh, my mom just had a stroke or a heart attack at age 60, and okay, dig into that. Why is that? And so you can document and think about how that changes the calculus, if you will, in terms of their own risks, because you know that so many of these things are tied to family history. We know about sudden cardiac death. There's a history of sudden cardiac death in family members. We might need to think about that. Same, multiple family members with intracranial aneurysms that warrants screening in, their first degree relatives. So the importance for the primary care provider to periodically update that family history, in addition to coaching and reassessing people on their modifiable risk factors, is of the utmost importance, besides the things that we've already mentioned today.
That's great. I was just thinking while you're talking, I remember when the Affordable Care Act just first unfolded in 2010, and hot topics were patient literacy, engagement to change, are they ready to change? Self-management, patient self-management, all those things kind of went to the side, but we still need to, I think, embrace those things to engage patients in change. And where is the patient, the family, the caregivers? Where are they in that whole process?
Sure. So, of course, the patient is front and center, especially in the primary care setting. But, if there are family members present who are willing to be partners, it's also important that they, with the patient's consent, of course, understand what's being discussed, because sometimes, it takes more than one person. It's very common for patients to leave the office and, what did he or she say about this again? And so it's important to educate them as well. If you've unfortunately already had a neurologic event, most likely it will be the family who's educated rather than the patient, for reasons we've already cited. And so one thing I find is that written information, easy to understand format, is very helpful. And then, kind of return demonstration as a teach-back method, if you will, to make sure that both family and patient understand. And a lot of times you will need family buy-in, sometimes depending on the patient, to make sure that certain outcomes happen.
Yeah. I always talk about, we have the medicines, right? We have the things that can change, but I heard Dr. Mark Hyman say that, there's medicine at the end of the fork. We have to, go right, like you said, go back to the basics. We really appreciate your expertise. Is there anything that you think our audience needs to know or should know?
I would simply say the old adage, an ounce of prevention is worth a pound of cure.
Yeah. I keep talking that we need a diagnosis, an ICD 9 or an ICD 10 code for denial. You know,
Very
I don't,
true.
yeah, I just, I don't think people understand the consequences of their choices, and what can happen. And you see it, from my, it's a trajectory from where I am to where you are, what I'm trying to do and what eventually happens, because of denial or, people get comfortable. They don't want to modify their diet or their lifestyle.
Yes, and the corollary to that being respecting current scientific standards and seeking preventative care on a regular basis. Many people come because they have not seen any provider for preventative care in a number of years.
Yeah, and it's amazing to me, providers who don't understand the guidelines, right? The new lipid guidelines just dropped the LDL to 70, you know?
Absolutely.
So, yeah. Well, we really appreciate you, and we look forward to following you and your work. And if we can, highlight anything that you've done, let us know. We would be happy to do that.
And thank you for having me here. It's been a pleasure.
Yeah, absolutely.
Thank you for listening to the latest edition of the Multiple Chronic Conditions podcast. For more information about the Multiple Chronic Conditions Resource Center, visit us at www.multiplechronic-conditions.org. There you will be able to subscribe to our newsletter, answer surveys on specific topics, and much, much more. We appreciate your continued support of the Multiple Chronic Conditions Resource Center, and we will see you again in our next episode.